Hi, this is Dr. Rosemary from Frontier Kids Care, and we help parents who are anxious about their children's well-being in health, learning, and parenting. Well, welcome to Frontier TV, and today we have an amazing guest, Karen Kaufman, Dr. Karen Kaufman, who is an allergist immunologist. Did I get that right, Karen?
That is correct. Yes. Thank you so much for having me here with you.
And she's coming all the way from?
I live in Virginia in the United States.
Yes, in USA.
Right outside of Washington.
Virginia, USA, you know, lots of Trinis everywhere. So we know there's a huge community right there at your doorstep, and maybe you'll see them soon one day. So, yes, ma'am. So we're going to talk. We have a lovely conversation with the experts today, speaking to Karen about allergies and immunology. And we know a lot of parents are really anxious about their child's well-being with allergies. Dr. Rosemary, my child has sinus, so I have a head cold, as we say in Trinidad. What do I do? My child snorts all the time, or is milk causing me to have my child to have a lot of mucus? When I think when I have milk or flour, my eczema acts up. What is milk allergy? What are food allergies? Help, help, help. So Dr. Karen is both, she's board certified in pediatrics and adult. So she's really in a great place to answer some of these questions. So Karen, where do we start? Tell us what you do and how you do it.
Well, I help children and adults who suffer from allergies and problems with recurrent infections to feel better like they deserve and minimize their medication burden and regain the quality of life that they really need. And I have a private practice in the suburbs of Washington, D.C., where I am able to do that locally. So it's just a real treat. I am so blessed to be able to see people of all ages. So I start with children as young as infants, and I see people all through childhood and adolescence, and then I also see adults all the way up through their elderly years. So it's just a real treat for me.
Well, that's excellent because you wide the full spectrum. Excellent. So tell me, in terms of your pediatric population, what are your main things that you see?
I would say in our youngest patients, a lot of the evaluation starts with food allergy and eczema. That tends to be, the most common things that I'll see generally in children up through maybe the age of 3 or 4. And around that time is when we start to really see a lot of the presentation of symptoms of environmental allergy, allergic rhinitis. And that comes with time because here in Virginia, we have, 4 very distinct seasons in our year. And so our pollen burden really is variable depending on what season that we're in. And so in children, you really need to kind of live through that season of pollen exposure to become initially sensitized, that ultimately reactivity here tends to follow in subsequent seasons. So, it tends to be in those kind of preschool years that we start to see some of that development of environmental allergy. And then asthma comes along with it. So, I think we see more asthma here than you guys do in Trinidad and Tobago, but, we see asthma not only seasonally due to environmental allergen exposure, but of course we see a lot of wintertime asthma flare in the setting of viral triggers, and, respiratory irritants are always a big trigger. And maybe in older kids, more so eczema, exercise-induced asthma tends to be a bigger issue. So those are some of the biggest things. Of course, I see lots of hives. Hives and swelling are never out of style, so I see that here. It's a lot. It's a big gamut. And then, a lot of pediatricians also refer patients to me who have a lot of problems with recurrent infections. So, recurrent ear infections or sinus or pneumonia, those children, where they're either having too many infections or infections that are requiring kind of prolonged courses of antibiotic therapy, or infections with unusual features, they should be evaluated by an immunologist to make sure everything is normal from an immune standpoint.
Okay, excellent. Thank you. Well, in our setting, we have two seasons, more or less, dry and wet, rainy season, dry season. But our allergy season, in terms of asthma especially, is like from about October to February, March. That's like when we see the burden of, the respiratory problems. And in between, we do have the burdens of allergic rhinitis. Because we don't really necessarily know have tested what pollen burdens we have, a lot of it is empirical,
Sure.
For example, a mom might tell you, whenever I go by this mango tree that's flowering, my allergies flare up. And since we know that allergies tend to be some sort of genetic predisposition, we may assume that the child's allergy flaring up maybe because of that same, particular pollen-bearing tree. But we don't have like the burden of pollen-bearing trees, I don't think, as you do.
Yes.
What we do have is Sahara dust, at least is what we call it. And we can, and that seems to come across from the Atlantic and in bursts. And sometimes when that happens, we do notice that there is an uptick in children with allergic conjunctivitis, which is the itchy, watery, runny eyes, and allergic rhinitis, and sometimes the asthma. The asthma is usually respiratory. This is why we know this, again, empirically, because we've been in lockdown for over a year and children have not been in school. There's just no asthma. It's almost non-existent. They're not getting respiratory infections. Yeah, that's one good thing. Yeah. So that's from our side of the Atlantic.
Very nice.
So tell me, we get so many parents asking me, my child, does mucus cause allergies? Does milk cause me to have a lot of mucus in my nose? And there's lots of questions around milk and rashes and milk and nasal congestion.
Sure.
And we're a very milk drinking country. People just drink so much milk and they have a lot of questions about it. So tell us something about that if you can.
Milk is very popular here too. We talk a lot about milk.
Yes, I know.
So I will definitely say, let's start with milk in the skin.
Yes.
So in children who have eczema, and
Yes.
this is kind of how I explain it to parents. So in children who have eczema, the reason that they have eczema comes from some kind of dysregulation of immune cells in the skin, right? So you think about the skin as an immune barrier, and it keeps us, right? It keeps the inside of us safe from the outside stuff that's around us. And so, the immune problem with eczema is not that these cells are completely dysfunctional. They're just kind of tweaked. They're just doing kind of the wrong thing a little bit.
Yes.
And that can be triggered by a few things. It can be triggered to some degree by our genetics, which we have, have no control over, right? Thank you, mom and dad. These are the genes that we got, right? Yeah. So for some children, it's a genetic linkage, a genetic predisposition, and that is it.
Yes.
In some children, allergy is a contributor to why these cells are not working properly. So we see that with food allergy, where the only manifestation that some children may experience with food allergy is that their eczema is either present or it's difficult to manage.
Yes.
So we see that with, here in the US, we see it with some of the most common food allergens: milk, egg, wheat, soy, peanut, and fish. Those are kind of the ones that I tend to see most prevalently to trigger eczema flares. And so, by identifying, is there allergic sensitization to these foods, especially in a child with moderate to severe eczema that's requiring a lot of topical anti-inflammatory therapy, or they're just not recovering in the way that we, would expect to see. Sometimes by modifying the diet and pulling those foods out for a restriction will allow the skin to get better over time. And usually those are foods that at some point we can reintroduce. So definitely food allergy can solely manifest just with triggering eczema flare. So these may be foods that children eat and tolerate, however, they've got this eczema. So definitely we see that, and milk is a common one for that. The other thing that can drive eczema, and then I'll switch gears to answering your question about, milk and congestion. But the other thing to drive eczema are environmental allergies. So especially in infants and in toddlers who maybe haven't quite, you know, been exposed enough to some of the outdoor environmental allergens, the things we're really talking about are the allergens that are within the household. So house dust mites are a very prevalent environmental allergen that we see. And then also furry animal friends who live with
Yes,
us in the household. So
yes.
sometimes we can see, that allergic sensitization is really driven by those environmental allergens and that continued exposure. So then we kind of need to manage that aspect. So
Mhm.
that's kind of what we see in the younger kids with eczema. In older children, adolescents and teens, I also start to see an allergic contact dermatitis
Yeah.
that may develop, and this comes from kind of components of products that we use, like fragrance and common preservatives,
Mhm.
amongst others. So lots of different ingredients that we find in products that are commonly used that actually can contribute to making that eczema worse.
Good.
Uh,
Can we stick a pin a second and go
yeah,
back to the babies? So people will ask me a lot, mom is breastfeeding and she wants to know if the things that she's eating is affecting the asthma allergies, the eczema, especially like nuts or milk and so on. What would you say to that?
it's a good question. And so I don't know that there's necessarily a one size fits all answer, to be honest with you, because sometimes we see, that there are these babies that have maybe mild to moderate eczema, and, we can kind of get things under great control, and the mom may be eating an unrestricted diet, and then the child is better. Well, there's not a strong indication that mom needs to necessarily withhold those foods from the diet. I will say though that there are some children that have markedly severe atopic dermatitis.
Mhm.
And those children sometimes do, it does carry through, and that the expressed or past breast milk, the amount of protein that's in there is enough to drive that eczema. So I would say typically I like to see if control can be gained first. And
Mhm.
then if not, then we'll modify mom's diet.
Okay, perfect. Thank
Yeah,
you.
that's a tough one. I know I think moms put so much pressure on themselves to try and figure out sometimes too, like,
Yes.
why is this happening, or did
Yes.
I do something right, or this
Yes.
like guilt that they feel, which really is without a lot of merit, because there's just so many factors that are involved that it's
Exactly.
impossible to say that it's any one thing. Yeah.
Exactly. And so it's important for us to reassure them that it's not their fault because, sometimes we think eczema just is a simple thing, but to that mom, it's the worst thing ever
Right.
because she expects her baby to have perfect, perfect skin. And any variant of that is often quite distressing.
It is. Even sometimes, I will see children who, have very mild eczema, and it's tremendously bothersome to the parents. And I get it, as a mom myself, you
Yes.
want to look at your child and say, like,
Yeah. Yeah.
everything is fabulous.
Yes. Yes.
Time.
Yes.
Well, I'll shift gears and answer your question about milk and congestion. This comes up here all the time too. So, I would say nasal congestion, and also the sensation of what we like to refer to as postnasal drip, which is
Yes.
kind
Yes.
of this like
Mhm.
kind of drainage and kind of coating of the posterior oropharyngeal wall,
Mhm.
with a lot of times with mucus.
Yes.
Sometimes we can see that foods can drive that. It's actually not an immune mechanism as to why this happens, but we can see this with a lot of different foods where we start having increased upper respiratory secretions. So we definitely can see secretions go up, but sometimes interestingly, like the milk itself, which is kind of like a little bit viscous, can kind of also coat the back of the oropharyngeal wall, just like
Mhm.
mucus does. So sometimes it's hard to distinguish the difference.
Okay, good. I think somehow maybe the internet was a little
Oh, I'm sorry.
something. No, no, no. I think we missed what you said about milk. Is it immune and the skin allergies? Is it not the skin? Sorry, the nasal congestion, immune
The nasal
mediated or not?
So typically when we see milk to be a problem with nasal symptoms, it's not an immune mechanism.
Okay, that's what I
Yeah,
thought you said.
it's
Yes.
not an immune mechanism, correct. And we see this with other foods as well. There are a lot of ingestions that can drive symptoms of rhinitis. Most commonly, we see this as a form of what's called vasomotor rhinitis, which
Right.
yes, which vasomotor rhinitis is really a problem that we can see with inspiration of respiratory irritants.
Mhm.
We can see it driven by cold air, which
Yes.
probably don't have much of in Trinidad and Tobago, but here in Virginia we do get some cold air.
Yeah.
And then certain foods can do this as well. So what happens is with ingestion, let's say, of some of these foods, the nerves in the central part of the face get stimulated.
Mhm.
And upon stimulation, blood vessels within the nasal cavity will begin to dilate. And that's when our noses start to secrete. And
Yeah.
so, yeah, it's interesting. We see this also here in Virginia, driven by pollen allergens too. And people
Yes.
come in, with complaints of environmental allergies, or
Yes.
the child is having all this nasal symptoms,
Mhm.
congestion, drainage, all of this stuff. And they get it, historically, let's say in the spring and fall, which here we tend to have very large particulate burden of our pollen.
Mhm.
And here in Virginia, like the pollen settles all over stuff. So you see this yellow dust on everything.
Mhm.
And as we inspire this, we have all these symptoms. And so, many of these folks will come in and they've tried various over-the-counter allergy remedies, and they come in and they say, well, I must have the worst allergies around because none of this stuff works for me.
Yeah.
And the problem is that it's a non-allergic mechanism, and it's truly vasomotor rhinitis. So what they're doing is treating the wrong problem. And patients get really frustrated. They're like, I have allergies. And it's like,
Yes.
well, allergens are contributing to your symptoms, but the mechanism is different. And same thing with milk in this case. So
Yes.
it's very fascinating to think about,
Interesting. Yes, it
the
is.
nature of
Yes.
this. Mhm.
Oh, great. I like that. This is good
Very
stuff. So
good
maybe
stuff.
it's a cold milk. If you're drinking, maybe it is if you're drinking cold, it's actually the temperature, maybe not exactly the actual drink. That's interesting. Yeah, but people swear to you that
Yeah.
milk causes mucus. I don't know if
I
it's
mean, and
the
it
M and
may,
the M.
yeah, it may do that. That is not that is not far from the truth. It's just that it's not an allergy. So,
Yes,
so when we talk about any kind of food intolerance,
yeah.
which is, what we consider food intolerance are the spectrum of symptoms that happen because of ingestions of foods that are not directly triggered by our immune response.
Mhm.
These are what we call food intolerances. The way to manage it is to modify the diet. So it's perfectly fine to say, look, I get a lot of congestion from milk.
Mhm.
Let's try and decrease the volume or
Yes,
whatever, or decrease the frequency and see if that
yes,
helps. It
yes,
probably will,
yes.
but it's not your immune system
Yes,
that's
and
doing
that's
it.
probably what we see the most and that we can help with. So we typically, I would say, well, stop the milk or whatever it is for about 2 weeks, see what happens. If there's improvement, well, then stay like that. You can try it back and see if it acts up again. Well, then, this may be a particular food that you have to avoid.
Right.
So, or,
And I think it's important too to differentiate that, this is a different type of problem with milk that we see compared to like our primary food allergy, which is a problem of immediate hypersensitivity from milk.
Mhm.
And so, I see children who have primary food allergy to milk where just a tiny, trace amount of milk protein will trigger symptoms within the spectrum of anaphylaxis. And those children do need to strictly avoid and have an adequate emergency preparedness plan and carry epinephrine.
Yes, yes, right. And that's particularly, well, that would be uncommon or much less common. Much,
Yeah.
much less common. And things like that, you absolutely need an allergist for.
Yeah.
So this is where you come in and we can manage more the food intolerance things, which are more common. Yes. Somehow I think we have a little, this internet is Sunday morning laziness.
Nutritionists can certainly do that.
Mhm. Excellent. Our internet is lazy this Sunday morning. I know, it's just sleepy. It hasn't woken up yet.
No, that's okay.
So yeah, that's excellent. So I get that. That's a very good point. So going on to these household, in terms of your allergic rhinitis, what
Yeah.
would you tell parents in terms of patient education? I mean, in our situation, we're not that big on, excuse me, household pets in the home, but it's
Mhm.
becoming more and more common. So sometimes the other day I had this child, she has really bad allergic rhinitis, and no carpet. Okay, fine. Do you have any pets in the house? Oh gosh, yes, we got 9 cats, 9 cats. And she calls out all the names of all the cats, Bandit and Loki and all sorts of
Oh,
funny names. Just had me cracking up. And I said, well, let's see if the cats have to go or not. At least certainly be outside and let's see what happens. So typically in our setting, I would, do blood count and send for some blood allergy testing, which would be like screening tests. And I would probably do, the house dust mite, the cat dander, and a couple other things, food as well as environmental things. The dust mite, mold, not so common, but I do those things. So tell me about blood allergy testing from our layman's term, patient's
sure.
layman's term, and what do you do and what's the use of it? And when do we now move on to skin allergy testing, which would be your domain?
Sure. So really, when it comes to the evaluation of allergy, both are good. Both types of testing are good options. So it really depends upon, ease of obtaining that test. For you in Trinidad and Tobago, it's going to be much easier to start with blood testing, which is it's not a bad place to start. So what we're talking about with blood testing is testing for specific IgE antibodies, which are allergic antibodies that would specifically be present for individual allergens. So that's where we can start with testing. And that's very, very reasonable in your setting to say, look, are there antibodies present? Yes or no, and how high are they? For us here in the US, I typically will start with environmental allergy testing with skin prick testing. It's a little bit more sensitive and more specific. And what's nice about it for me is I get answers in 15 minutes. So we can get the answer to that test during the visit and then go ahead and move forward with, making our plan of care right away. So that's preferable here because of, that's, it's easy and it's convenient and things like that. So here for environmental allergy, I tend to utilize the blood allergy testing more in individuals, who either have very sensitive skin to the skin prick itself, which is something we call dermatographism. So it's a physical form of hives that can happen just from scratching or pricking the skin. So those skin tests become very difficult to kind of interpret. And the other group of patients who I would tend to do blood allergy testing are in individuals who really need to be on medications that would interfere with the test. So, antihistamines need to be withheld prior to allergy testing. In some folks, let's say, who have, really bad, let's say, eczema, or, they're on antihistamines for their itching or hives, or even some children who are being managed for other problems like maybe ADHD. Some of those medications can interfere with our skin testing, and the blood allergy testing becomes preferred for those individuals. But what we're looking at, is kind of the same thing in two different ways. So with the blood test, we're measuring specific IgE antibodies, which are allergic antibodies that would be, specific to each individual allergen. With skin prick testing, we're looking for a local response of histamine at the site of the skin prick, which would be elicited by the presence of those IgE antibodies that trigger that histamine release in that location. So it's kind of two different ways of looking at the same stuff. So beneficial in both regards. With regard to food allergy testing, I often will do skin testing at the time of diagnosis. Again, same thing. Parents come in, they have a clinical history of, I've been introducing solid foods maybe in the first year, and, my child had, let's say, a piece of pancake or something that was made with egg and immediately started vomiting. And so then the question is this egg allergy? So they want to get an answer that day, so skin testing is very valuable because you can say, okay, we have a positive skin test. It correlates with the clinical history. This is egg allergy. And then we can go ahead and do the educational portion of, what new food allergy parents really need to learn. And then how to, have good emergency preparedness and things like that. But over time, I do utilize blood testing, specific IgE allergy testing for foods, kind of to be able to track things. So we want to reevaluate and say, is this child growing out of this food allergy? it allows us to use that same test and to kind of compare that same data point over time to say, look, we're seeing downtrending, and this may be a good indication your child's growing out of this allergy.
Nice. So I guess the two things I heard from you is that the skin allergy testing is more specific than the blood allergy testing, which is probably better, more like a screening test, as well as the fact that it is, I just lost my train of thought. You said that the skin allergy testing is more specific, and of course you can get it back right away in your setting. But
yes,
in
but in yours you can't. Yeah,
we can't. So we probably do the blood allergy test and get it back, and then see where we go from there if we have to refer or not.
exactly. Exactly. And I would suggest, like when it comes to what do you test, what do we test for? What I would suggest is to test for the relevant allergens that are present in your locale, so, and that's how it is even here. So, the United States has a lot of different climates and a lot of different types of terrain depending on where you are, and different allergens go along with that. So we tend to test here in Virginia for stuff that's pretty localized to where we are.
Right. And what are some of those things that are particularly problematic in your area?
Probably the most problematic from an environmental standpoint is going to be the tree pollen, which is a spring pollen for us. So the trees, we have just such a wide variety of species of trees here in Northern Virginia that they probably cause the most misery around here. And also I think it's hard because, the climate has been kind of warming a little bit, and the water levels in the Chesapeake Bay are going up, and that definitely plays a role with lengthening our pollen seasons a little bit each year.
Oh, really?
Yeah, so it's interesting. Yeah, the climate change has been a contributor to this as well.
It's a real thing. Very interesting.
Yes,
so what we do, like, for example, even when we do this, refer to an allergist to do the skin allergy testing, it's difficult because the things that trigger allergies in our setting will be different from the kits that are available so many times, so you really don't get a lot of positive reaction to the pollen bearing allergens.
Right. It's actually interesting because they always say, for any allergist who moves to a new area to start practicing, like the first thing that you want to do is contact the local botanist and find out what the most prevalent plants are in the area where you live. So very, very interesting.
So the closest we can get to probably is Florida, so we tend to look at but even then it is going to be different because we are the last island of the Caribbean archipelago, all the way down and very, very close to South America. So we really have each Caribbean island in itself has unique geography because of their location. So even among the islands, you don't have any continuity as such, which is very interesting.
Right.
So that's a big thing. I heard you say something about hives and also about vomiting. Those two things I want to ask about. So you often find a parent will come to you and say, my child had milk. I had it last week. Somebody told me this. They had eggs and they vomited first time. They're 9 months or 1 year being weaned. And I've given them egg twice and they vomited egg twice. How commonly is that an allergic reaction? And sometimes is it just not liking eggs and being, sometimes the children will have the same reaction to other things. Tell us about that a little bit. And then afterwards, tell us a little bit about hives and what things trigger hives and how we treat it.
Sure.
When it's chronic.
So, in infants, vomiting following the first couple ingestions is concerning. So to me, think about the symptoms of anaphylaxis, or anaphylaxis is a word that we use just to describe a multiple body system allergic reaction. There are 4 major body systems. This is kind of what we kind of simplify and divide under which these symptoms might fall. So in the course of a food allergic reaction, people don't always have symptoms from all of those groups, but they do have symptoms from at least one or some. So the different body systems that we see include skin symptoms. So when we see skin symptoms as part of an allergic response, like a food allergy reaction, for example, we're often talking about hives, swelling, redness, itching, or flushing of the skin. And I'll come back and talk a little bit about hives afterwards, because that's a whole nother animal. But that's one of the body systems we can see in the setting of an allergic response. The second is respiratory. And these respiratory symptoms following an ingestion may be something like profound coughing, it could be tightness of the chest or labored breathing or even acute wheezing following an ingestion. And again, these symptoms of immediate hypersensitivity typically fall within seconds to minutes to maybe an hour or two following that ingestion. The third group is the gastrointestinal symptoms. And so this is what maybe that child had experienced. So usually we're talking about some kind of swelling in the gastrointestinal tract, whether it's swelling in the mouth or throat or even in the gut. And that may manifest with severe abdominal cramping, profound nausea, vomiting, or diarrhea. So again, we're talking about an ingestion following back by an immediate response. The last group, which is really hard to recognize sometimes in young children, these are the cardiovascular symptoms. And usually these are related to a drop in blood pressure, which is really tough to wrap our minds as parents around that, because of course no one walks around with a blood pressure cuff or anything. So in an older child or an adult, how we may feel might be lightheaded or dizzy, or we feel like we could pass out. In young children, kind of what I describe to parents is, as you observe your child, if they go from being a normal, active, like infant or whatever, to suddenly lethargic following an ingestion, that would be concerning to me. So, in that setting of something in that realm following, immediately following an ingestion, to me, I would consider that to be food allergy until proven otherwise. That would be worrisome to me. Hives, however, hives can be a lot of different things. So in children, when I try to sort out what's going on with why somebody has hives, there are two major kind of, not criteria, but two major factors, I would say, that I look to say, how do I separate this out, or how do I think about this the right way? And those two major things are, number one, is there an obvious trigger for the symptoms, right? Obvious triggers are obvious, so they're a lot easier, right? They tell us what to evaluate. Or number two, what was the time course of what happened? So was it a single event? Like the example you just gave with the child that vomited following egg, let's say it was hives following egg. Well, it happened that time, and then it was done. So single event. Versus some children will have hives that just seem to pop up out of nowhere. And they may be present day after day after day, for days to weeks even. And that's a different type of problem. So this is one of my biggest pet peeves here in the US, is when, let's say, this happens all the time. Let's say the child has a reaction of hives that maybe just popped up, and it's been going on 3 or 4 days, and the child goes to the urgent care or to the emergency room, and the doctor says, well, you must be allergic to something, and I don't know what it is, but you need to go see an allergist. Have a nice day. But oh, by the way, if something really severe happens to you, come on back. I just don't know what it is. And they're like, what? Drives me bonkers.
Yes.
So when we see hives, in the setting of an immediate trigger, whether it's an ingestion, whether it's a sting, whether it's following use of an antibiotic, whether it's with contact of environmental allergens, right? Like I pet the cat and I rub my face and now I have hives here, something like that, right? So those things tend to be related to allergy. Okay, so these are all mediated by IgE antibodies, as we've been talking about. And that's kind of a different scenario than more often when we see hives that, just seem to appear. Maybe the child woke up with hives and, they're present all throughout the day, and maybe they'll wax and wane. And the following day, they're still there. And the following day after that, they're still there. Most of the time when we see hives without an obvious trigger, we're talking about a response to a different type of antibody. So rather than being triggered by that allergic IgE antibody, in this case, it's triggered by the presence of IgG antibodies. And these are the antibodies that our immune system makes in order to, most of the time we see it in the setting of viral infection. So these antibodies help to eradicate pathogens, and they do their job, and we get better. And then sometimes we have these antibodies that kind of stay in excess of what's needed for a longer period of time before the immune system gets rid of those. and those antibodies contribute to the development of hives. So in this case, it would be more of a skin-limited problem. So we wouldn't see symptoms within that spectrum of anaphylaxis.
Yes.
Really just be a, like bothersome but not dangerous kind of problem. It still can be managed, but a lot of times just good reassurance is, is reasonable. Yeah.
Excellent.
Yeah.
Well, in the topic of food again and peanuts now, I know the American Academy has been going back and forth, and over time the recommendations have changed a lot. And
Yes.
of course now they are advocating that you start giving peanuts, some sort from age 6 months because of the incidence of peanut allergies. Tell me about that story and about the present recommendations.
Yeah, so the pendulum has truly swung both ways. And I would even say, going back, several decades to when I was young, I think at that time, the recommendation was to delay the initial, introduction of peanut and some of the other highly allergenic foods until children were like 2 or 3, much later. And so one of the ways that we think that food allergy one of the things that has contributed to the development of food allergy has been when the first recognition of that food protein has been through other immune cells that are not in the gut. And so, for example, you take a child with eczema who already has like inflamed and disrupted skin, who may, in the delay of initiation of peanut, let's say, into the diet, maybe they come into contact transdermally, maybe an adult who was holding a baby had, peanut oil residue on the fingers, and then, that got on the skin, and then those immune cells in the skin were the first to recognize. So sometimes we see that, these alternate ways of recognition of food allergens contributed to that development of allergy, where what we know is that babies best make immune tolerance by first recognizing these food proteins in the gut. So we kind of been teetering about, well, what do we do about it? And actually, when my children were little, the guidance at that time was, once you introduce kind of the more conventional stuff first, then just go ahead and introduce the more highly allergenic food without a great guidance. But back in 2015, when the LEAP study came out, or the LEAP trial came out, we really started to gain better definitive evidence that early introduction helps to reduce the incidence of peanut allergy. And so the guidance is actually, I think, to introduce the highly allergenic foods at some time between 4 and 11 months is what the recommendation is. And that's really valuable, I think, to parents because, hopefully we'll start to see things swing in the other direction. But at least here in the US, like I think between the late 1990s and the, just before 2010, I think the rise in peanut allergy was about 18% in the United States, which is dramatically high.
Yes. So has it come down now with this early introduction?
I don't know that there's a whole lot of data that's been calculated on it yet, but I'm very optimistic that, the data is really terrific. And actually what it looked at was it compared children who were in UK and children in Israel with timing of peanut introduction, because in Israel, historically, peanut had been introduced much, much, much earlier. And that's kind of where that data started to come from. So it's really terrific stuff. So I'm glad that we're starting to see some advances in the world of food allergy.
Nice, very good. Yeah, well, this is such good stuff. This is just good stuff. Another question people ask, and sometimes I myself wonder, a lot of the creams that we use have peanuts in them. Sometimes you see macadamia nut, or even oats as well is another thing that sometimes you can see. And I remember once having this baby who had really, really bad eczema. Like she could, and when we did the blood testing, she could have nothing. So the only thing she was not allergic to was oats. So she couldn't have wheat, cow's milk, flour, corn, and oats. But rice she could have. So she could eat like rice cereal and have rice as a starter diet and stuff. But so I found that she was just keeping on, not getting better right away. And then I checked it out, and she was actually creaming herself with one of these products like Aveeno, which has oats in it. And we had to stop that as well. So my question really is, how often do you see the topical creams having some of these constituents causing or worsening the eczema?
It's hard to know. I mean, it really is truly hard to know, but you know, I generally prefer to choose products that don't contain, food oils in them. So certainly we even here in the States we've got some with macadamia and almond oil. There was actually even a topical corticosteroid that was made into an oil that had peanut oil in it that
Mhm.
people were using for a long time, and I tend to find that you know people do a lot better, or eczema does a lot better to really limit the amount of stuff that's going on the skin as a whole. So and I feel like there's a lot of consumer interest in, organic products and
Mhm.
products that have really appealing labeling and things like
Yes,
that.
yes, yes.
And they have a lot of like even plant oils in them and stuff like that. And so it's really tough because, it seems like it's going to be so nice to put all this stuff on the skin, but really simplifying what's going on the skin makes
Mhm.
a big difference. And there is a website. This may be something that might be helpful for your parents in Frontier Kids Care. But there's a website that we often refer to, especially with our patients who have allergic contact dermatitis.
Mhm.
But for children with atopic dermatitis, or even just anyone with sensitive skin,
Mhm.
there's a site that kind of looks at some of the common contact allergens that
Mhm.
are present in various topical products. And I think the site right now has maybe about 55,000 products or so, plus
Oh,
or minus, that are on the site. So it's a website that's called Skin Safe Products. I don't have any affiliation with that site, but I just find it
mm.
to be really useful.
Okay.
Um,
Yeah.
and you can look up about different products, and they're all sorted by category and things like that. And so even, for me, I have eczema of my hands, and my two children had mild eczema when they were younger, and now they
Mm.
both just kind of have sensitive skin like me. I have type 2
Mm.
skin. My husband has darker olive Mediterranean skin, and my
Mhm.
children unfortunately got my sensitive skin. But
Yes.
when I go shopping for things like sunscreen or shampoo for them, or whatever it is that I'm shopping for, I'll often refer to that site and try and make choices of products that don't contain a lot of contact allergens in them.
Yes.
So I
Yes.
find that just to be helpful as a consumer.
Excellent. Can you repeat the name of the site? Skin
SkinSafeProducts.com.
Safe Product. That's pretty easy.
Yeah, it's pretty easy and it's a cool site. I feel like I should have some kind of affiliation with them because I talk about it all the
All
time.
the
But
time.
I'm just also, I'm also a mom and I'm also a consumer, and I just find it to be tremendously helpful. My
Yeah,
my patients get a lot out of using it too. So
that's very great. That's great. So
yeah,
we use a lot of coconut oil here, and
yeah,
sometimes some people it's perfect with them, and some it's not, and you really
yeah.
just have to play around with it and see.
Yep, absolutely. And the thing with coconut also, coconut is a common contact allergen. And so when we see contact dermatitis, it manifests by way of a delayed hypersensitivity. So it's a T cell mediated response.
Yes,
So
yes.
people may say like, well, I've used this for 10 years or whatever, and it's been fine
Yeah,
until it's not fine.
yes,
And it's like, well, yeah,
yes,
that's how
yes.
it is.
Yeah, so that's a thing that's very important to factor in. So
Absolutely.
I'm going to ask you for like say top 5 things you would tell parents with what to do in terms of you know allergy proofing the home for allergic rhinitis, the
Oh, that's
sniffies and the snorting and the snuffles and the sneezing.
You got it. Well, I always love to start with environmental control. So the more that, in general, the more that we can do without taking medicine, we should do that, right? So we want to, minimize the amount of medications that we're using,
Yeah.
especially in children. And so for as much benefit as we can get from environmental control measures, we should do those things. So, when it comes to house dust mite allergy, which I don't really, to be honest with you, know how prevalent that is in Trinidad and
Quite,
Tobago, but I know
quite,
that, yeah, I was gonna say, I know that they thrive in humidity, and I think with your
quite.
climate,
It's
it
huge.
probably is the big issue. So let's focus on the house dust mites first.
Yes.
So I will say house dust mites are different than just dust. So like if you can run your finger over the dresser and you get a little bit of dust, like that's not the same thing as dust mites. So
Yes.
dust mites are tiny little microscopic bugs,
Hmm.
and they're mites, and they're a little bit smaller than what we're actually able to see with our own eyes. So
Yes.
if we go looking for them, we're just not going to see them. But if
Yes.
we look under a light microscope on low power, they're going to be huge.
Yes.
So, you
Yes.
know, so they're part of our microscopic world.
Yes.
And while they do thrive in this humid environment, what they do and their purpose in the world is that they eat dead skin cells that have come off of us. Okay. So they're not going to like crawl up on us and like have a nice little snack of our skin. They don't really like us that much, but they want to be our neighbors and they want to be where we are. So where we find them most prevalently is going to be in the bed. And it doesn't matter how frequently you clean your home or how often you dust, they're there. Okay. So they're going to be in the pillow, in the mattress, in the sheets, and all the bed linens. And you'll also find them in the sofa and in the carpeting as well, especially the carpeting that immediately surrounds the bed or the sofa. So, not having carpet is beneficial, especially for, children with eczema who play on the floor, who may be sensitized to dust mites. For purposes of rhinitis, normal tidal breathing is not normally enough to extract dust mites out of the carpet. So that's a lesser issue, but the bed is where we find the biggest problem. So the simple environmental control measures that we can implement really include 3 things. One, which is washing all of the bed linens every single week in hot water. So the frequency of washing, but also the temperature matters. It's not required to use any kind of special detergents or any kind of, stuff to like kill the mites or anything, but just washing in hot water makes a difference. So getting all those bed linens cleaned, very important. For the pillow and mattress, which obviously, you could probably wash a pillow. It would kind of mess up the distribution of the fluff that's in it, I guess, but mattress certainly too big, right? You can't wash your mattress. So they make these things called encasement covers, which are these full zipper enclosure covers that go around the pillow and mattress on all sides. And these are super effective. And there's actually a lot of data to support this, in that the weave of the fabric that makes up these covers is so tight that it literally serves as a physical barrier between your body and the mites that will be within the pillow or mattress. As we breathe when we're sleeping, we're not going to be breathing in and out these allergenic particles. Okay, so that's very beneficial. And then the last thing is to try and keep the humidity in the bedroom low. So we want to keep the air in the bedroom cool and dry if we can. That tends to help. So that's pretty much the big thing when it comes to the dust mites. Animals, like for your patient with 9 cats, there's not a lot of hope. I'll tell you, cat allergen is so hard. So cat allergen is one of the smallest inhaled allergens. It's smaller than 5 microns, and it stays aerosolized for days, and it literally sticks to everything. So believe it or not, even there's data that supports that even for individuals who, let's say, find a new home for their cat and then deep clean their household, we're talking about a period of 4 to 6 months.
Oh my
before
goodness.
that cat allergen goes away. That's one cat.
Oh my goodness.
Cat. So 9 cats. That's a tough one. I would say for folks who do have pets in the household, though, it's important to try and keep the pets out of the bedroom if possible. And something that some people will use is one of those like plug-in HEPA air cleaners that will kind of pull some of these allergens out of the air. I don't know if you guys have that down in.
You can order it. Yeah,
you can order it. So that like might be helpful, but there's not a whole lot of data to say that it really reduces that allergen. And then, the other thing about animals, so here in US, I would say, the most common house pets are probably cats and dogs. And many people who have cats have indoor cats that don't go outside. Some do. But dogs are all inside-outside pets. And so in addition to folks who sometimes will have dog allergy, sometimes the bigger problem with dog is that they're bringing all the pollen in. So whether it's grass pollen or tree pollen or weed pollen that's now on the dog's hair or fur, even those hypoallergenic dogs that are the low shedding dogs still can contribute a lot to symptoms. So frequent bathing of our pets is important.
Oh boy, Karen, this was so amazing. We could go on and on, but we won't, because there was really such good stuff here. I mean, really very relevant, even though we're, separated by some ocean or sea. It's been great. It's been fantastic. So we can't wait for you to visit Trinidad and Tobago someday.
Oh, me too. It's the top of my list. Get that Pico Plat house ready. I'm coming.
Yes. We definitely have to have you over to Trinidad and Tobago someday soon. But this was really, really good. And thank you so much for this conversation. Tell us where we can find you.
So my office is called Kaufman Allergy, Asthma, and Immunology, and we are located in the suburbs of Washington, D.C. in Vienna, Virginia.
Yeah.
And you can find out more about me on my practice website, which is kaufmanallergy.com. And I'm also on social media on Facebook at Kaufman Allergy and on Instagram at Dr.Kaufmanallergy.
That was amazing. And she has a waiting list. But I'm sure we can get in there. So I'm pretty sure at some time we'll be doing some collaboration with, patients from here who may come up. People visit the, Washington area, DC area a lot. So in the near future, I'm hopeful that we'll have some more collaboration, non-virtually.
Just call us Frontier Kids Care North, right?
Yeah. Oh, that's nice.
So good.
Thank you for being on. And those who know us, you can find us at frontierkidscare.com. We have our Instagram, Facebook, and of course our YouTube channel, which is what you're looking at now, Frontier TV, part of our learning, not waiting menu, so that you don't have to sit and wait. You're learning while you're waiting. And of course, it's all virtual now anyway. So thank you, Karen. Take care. It was really, really lovely.
Thank you, Dr. Rosemary.
We'll see you again sometime very soon in the near future. So everybody now, take care with those allergies. Listen up. It's good stuff. And bye for now.
Bye.